These are my disclosures. There's quite a lot of them, and I do acknowledge that industry have been pivotal in helping us develop some of the services that we currently have, particularly some of the stuff that's a bit more blue skies than you may be able to convince your local organisation to fund. So Novartis and AZ particularly have been very helpful in allowing us to do some what we think are quite innovative approaches. So we cover the north of Greater Manchester, so basically this area, so 7 hospital sites. One of the important things I think from a renal perspective is because we work in a hub and spoke model, there is always the risk. We're based here, a lot of our patients obviously based out here. There is the risk that we don't provide a balanced service for the cardiorenal metabolic patients if we're predominantly in the hub sites. We are conscious of making sure that everyone across the patch gets as an equivalent service as we can provide. The Salford structure is quite broad. I appreciate I've got the balance wrong between the size of the writing and the size of the screen in the room, but ultimately there's an awful lot of components that you have to provide if you want to cover all areas of care for these patients. If you try to process map where our patients are vulnerable to changes in optimisation of care or admission, there's huge numbers of points along that pathway you have to address. So we started off, we've got 3 existing and now long-term clinics. I do a regional renal heart failure CKD clinic. It's roughly 50-50 hFPEF and a reduced ejection fraction. I have very, very loose referral criteria. I'm happy to see anyone where they have CKD and they have heart failure and they think there is value in them coming to this service. I find that because they're very, very complex multimorbid patients, if you have quite narrow criteria for referral, there's an awful lot of people who just fall between the gaps and miss out on that level of service. So Penny's going to talk a bit more about her clinic. We've kind of based it the 40-40 clinic, and if your GFR and ejection fraction are less than 40, then she will manage them within that one clinic. So we're focusing obviously on the 4 pillars of heart failure treatment, but also early interventions for general nephrology type patients. So blood pressure management, proteinuria, anemia, bone disease are all things that can be managed within that context. Again, one of the issues around the historic sort of MDT clinics where you've got a cardiologist and a nephrologist in a room, the clinic appointments are quite long, it's just not good value for money for an organisation, and things are very, very tight. Well, I do think you can have one person, one clinic providing cross-specialty care. I've got some slides in a minute just to show sort of the value of it. We also have a drop-in clinic. It started off as a drop-in clinic. It was run by an AMP who was a former heart failure nurse who went into emergency medicine and works in same-day emergency care. So this was initially badged as an admission avoidance drop-in clinic, but what we found was that it was effectively a frailty clinic where the patients were extremely vulnerable. That older group who have cardiorenal metabolic disease, but also advanced frailty, they're always on that cliff face of admission. So Mel focuses much on rationalising care and looking at the long-term outcomes for these people rather than just trying to fulfil the QI and audit plans we've got of getting as many people on 4 pillars as possible. We do provide a lot of remote support as well. So the classic MDTs, we have a monthly MDT with each of the heart failure teams around the region. Now, admittedly, I don't always attend all of them. Heart failures, I think, MDTs can be quite inefficient. I mean, the Pennine hospitals have one MDT every week, and there are often 15 or 20 people on there, and an hour and a half of your time for one patient is not necessarily efficient. So we added in an online advice and guidance service. So it was initially email-based, now web app-based. So last year we got around 200 referrals into nephrology from heart failure teams across the region using that service. Only about 1 in 4 needed a new patient referral, but it's a good way of being able to triage who comes into here and who can go elsewhere. We also refer out, of course. It's a bilateral communication, isn't it? But we found a real efficiency in that even if I don't see the people just in my clinic, I can see them there, I can communicate with the Bolton team about what bloods I've got, what plan I've done. They'll see them in 6 weeks to see whether my plan has improved things, and then you can do a stepwise integrated care plan across the patch. And it's immediate. We have a 96% same-day response rate, whereas you have to wait a month for an MDT sometimes. And our patients can't wait a month for changes to their care plan. And then the diabetes care, again, I do confess my focus is predominantly on heart failure CKD. There is a separate work stream of CKD and diabetes within our clinics. For example, the heart failure team do some of their clinics in the renal outpatient department, and there are diabetes clinics also in the renal outpatient department. So there's good cross communication. I'll have a quick slide on what we can do in our clinic, but there are certain things. I mean, I sort of think that a lot of diabetes care, it scares me, and it's especially the diabetes nurses do a job which is a lot more removed or a lot less intuitive for me than the heart failure work. Again, underpinning all of this is staff training. So Bolton University, we've paired up with them. They've got a really good advanced practice course. We now have a heart failure module there. So that's a 20 credit level 7. It's a Tuesday morning for 13 weeks. There's an elderly care module, palliative care module, acute medicine module. It's not targeted specifically at heart failure nurses. Anyone doing their advanced practice training or existing specialist nurses who want to do a module within their specialty. And again, we are introducing the renal module next, and then diabetes after that. So the renal module is probably got more of a focus on AKI as much as anything else. So at the moment in the heart failure module, we have physiotherapists, we have existing heart failure teams, people in training, acute medical trainee, specialist nurses, we have renal nurses. And the idea is to be inclusive, isn't it, and train everyone who needs to be trained, because there's so many touch points. We also do clinical placements, and I mean, Penny's done this. We've had heart failure nurses and consultants come and do a week or two within the renal department to help them see this whole arena from the lens of the nephrologist, and you do get a much better granular view of the renal angle of these patients if you do a placement within the department. I do strongly advocate for that wherever you are. Go and spend some time, ring-fence time within the other departments. Things in development. So we've got hyperkalemia and AKI clinics in development. We're trying to cross-cover primary care through a GP pharmacist. There's that whole population of people who historically were not optimised because of AKI and hyperkalemia. They're still out there somewhere. We're going to try and find them a link with primary care. But also, we talk about that triangulation between primary care, secondary care and community services, but the other big component is inpatient services. Because for as much as you want to optimise your patients, if you get them on all 4 pillars, they're going to end up in hospital very, very soon after you've done that, and then they're going to have their medicines absolutely obliterated while they're in. So if you have a really, really good outpatient structure and you get everyone on their therapies, you have to still make sure you've got a footprint or you've got good communication with inpatient services and ambulatory care. Otherwise, all of your efforts are going to go to waste. So in our organisation, 2% of admissions are because of heart failure, but 11% of admissions occur in people who have heart failure as a comorbidity. And 1 in 3 people in our hospital who go in on RAS inhibitors come out without them, without any evidence of AKI, hyperkalemia or hypotension. And of course those ones that go in with an AKI, for example, they get all their RAS inhibitors to stop, their frusemide stop, they get loads of fluid, they get a discharge letter done 6 weeks later, it's sent to the GP, but it's not sent to the parent team. And I appreciate that the inpatient components of heart failure services can't see every patient with heart failure in a hospital. I mean, Penny will describe her service. They cover community and inpatient services, which is a huge benefit to us to getting people into these clinics. But if heart failure CKD patients with an AKI, we see 1 in 6 are back in within 30 days, 1 in 3 back in within 90 days, and half of them are back in within 6 months. So I do think good communication with inpatient services is absolutely important. So just a few slides on some of the work we do. Again, focus on getting people onto the 4 pillars of therapies. This is people with CKD, get them on the 4 pillars of therapies. Alternative, we do use hydrolazine, nitrate, and we've been talking about using digoxin more, but by doing that, it manages the CKD. So if you get people on better heart failure therapy, this is pre and post referral, proteinuria improves, blood pressure improves, GFR doesn't really change. So in the nurse-led clinic, so about 3/4 of the people that go into that clinic fit the renal referral criteria, the NICE 203, and if they are managed in a single clinic, just within Salford, this doesn't include the outlying DGH services, you can potentially increase your capacity by a huge amount. But this doesn't necessarily mean you see more, well, you will see more patients, but you can provide a better service for the ones you've already got, rather than just waiting 4 months before seeing them again. Again, we're starting to do more and more irons. About 20% of our heart failure patients fit the criteria for iron. The renal services dish out maybe 1,000 doses of iron per year. It doesn't make sense to try and set up a parallel iron service for a population which has that huge overlap on the Venn diagram. So at the moment, we are incorporating IV iron for heart failure patients into the renal IV iron pathway. It's a much more efficient service, and we can get people in usually very quickly within a few weeks. I've put a couple of vitamin D ones there. We're doing a lot more now. I think that's probably early interventions for renal bone disease. I think is where we're probably getting the good the good outcomes. I'm just going to have a nod to Tony, who sat over there by the noisy door. She's a renal nurse specialist, does a drop-in clinic, and fluid overload, 56 people, fluid overload and blood pressure control, and then post-discharge review, again, many fluid overload patients. Probably 100 people per year, purely from within a renal service with fluid overload. And there is a huge amount of overlap that Penny and her team could assist with this, and Tony and her team could assist with heart failure team. There's just a huge overlap between what they do. And then again, BP management, which I think is, I don't think we focus enough on BP. In Tony's clinic, a massive improvement in blood pressure. This is our advice and guidance service. This is just a snapshot of the type of thing we get from the district general heart failure team. It's a fairly broad base of referral reasons, but only about 1 in 4 actually need a new patient appointment. It's a very efficient way of looking at things. I do need to shut up. I've been instructed to very clearly, very politely. So diabetes does scare me to some extent. I mean, there are things we can do. I stop the sulfonylureas as much as possible. I try and maintain people on metformin when they like it. Obviously, there are drugs that we use outside of diabetes anyway, but there's plenty we can't do, or that I don't think that I've got the skill set to touch on. And maybe that will emerge over time, but I think the role of the specialist diabetes team is one that I say frightens me. Right, so that'll do me. On that note, over to Penny.
Hi, so I'm just going to give a quick overview of the service. I think Darby said most of it already. So this will be really quick. So this is what our team structure is, and we do work on band 7s if anybody wants to photograph that and use it as so basically we have quite a large hospital, and our community population is quite large with our current caseload of 295 patients. So the criteria for referral is that we see all inpatients with a primary diagnosis of heart failure, and we follow all the patients who have an FREF of below 45% in the community. So we get to know that they're in hospital via our inpatient EPR system, which tells us if they have a health issue or that says that they've got heart failure, which can help us to pick up patients who we wouldn't normally get a referral for. So that is quite good, and as Darren said, we can find out when patients have had a lot of their medication stopped for various reasons and try and put them back in place if possible. So this is just a quick thing of how our service works, and Our ODTs are what really helps us to function well. We do this one weekly with our consultant, but monthly with people like palliative care, renal consultant, diabetologists, geriatricians, and our device lead, which helps all our questions. So the interprofessional working, as Darren says, we've been working closely with the renal team, and what we found is that we work very, very similar, which is, it was really scary, I think, at first, because you're going into a different speciality and you feel like you're quite knowledgeable in your own, but actually, sitting in with Darren, he's asked exactly the same questions that we asked, and it's changed the way we work in respects of when we get new patients, we're now looking for renal disease, we get patients who have diabetes, and we're seeing if that well controlled, do they need referral onto our community diabetes team. So basically, because we work in the hospital, I feel like we have a good catchment to pick up patients and then follow them up in the community. Unfortunately, we can only follow up patients who have a GP within our catchment area, which can make things awkward, but we generally refer them on. Thank you.